Will you tell me if the typical form of folic acid, typical supplemental form of folic acid, is not only not helpful, but actually harmful to those people who have the genetic variant that requires them to take the methyl tetrahydrofolate form? The background information on this, doctor asked the question, my nephew is 11 years old who has suffered serious health issues since Christmas in 2016. He's now been diagnosed with Lyme disease. It is, by the way, Lyme disease, not Lyme's disease. Everyone calls it Lyme's disease. It was based on its first discovery in Lyme, Connecticut, so it's Lyme disease. And many people call it Lyme's, but it should be called Lyme disease. He's now been diagnosed with Lyme disease and the genetic variant, or SNP, requiring 5-MTHF. His mother has done significant research into these mutations, says that there are several different gene mutations requiring 5-MTHF, and her research suggests that the regular folic acid is harmful to those with the mutations. She reports that as much as 75% of the population may have a mutation, and folic acid routinely given to pregnant women and included in enriched foods is aggravating their problems. Well, this is an issue that I was first introduced to by Phil Maffetone a good number of years ago, and the issue is looking at folic acid versus folate. The answer to the folic acid question is a bit complex, but the bottom line is that it appears that some people, after prolonged folic acid supplementation, will react negatively to it. Now, I have to put that in context. I've been doing this for a long time, so I'll put that in context as I answer this question. Unmetabolized folic acid, which is sometimes called UFA or UMFA, can build up and create problems in some people. This is a picture which we got from MTHF Support Australia website. This shows folic acid in supplement or fortified foods as opposed to dietary folate from normal dietary sources. You know, folic acids from foliage like green leafy vegetables, and the folic acid from dietary folate or the folic acid from supplemental or fortified foods is worked on by an enzyme called dihydrofolate reductase, and it's a slow mechanism to produce the tetrahydrofolate here, more fast from coming from dietary folate, much more faster introduction into or conversion into tetrahydrofolate. But what happens is this slow conversion of folic acid in supplements or fortified foods of folic acid, not folate, but folic acid, can allow the folic acid to become unmetabolized into what we call UMFA, or unmetabolized folic acid, sometimes called UFA. And this can build up in the tissues in some patients and create problems. So I've had many patients on folic acid for decades sometimes. If I took them off it after a while, they test as needing it again. They maybe were anemic, had megaloblastic anemia with a high MCV or something. We took them off it would show up again. So I've just kept them on it with no known adverse side effects, some for many years. However, when I first heard about the unmetabolized folic acid, or the UFA or UMFA, I started testing some of these long-term patients that repeatedly tested positive for folic acid. And I found often a subtle weakening, maybe just like the liver, maybe just the pectoralis major sternal, for example, or maybe they had some recurrence of some muscle. Maybe it was a tensor fasciae lata or a latissimus dorsi, or some muscle that tended to recur, gluteus medius or something. And I would test the folic acid against that muscle that was recurrent after I strengthened the muscle. And I would tell you that I couldn't say that all these patients that had this problem would show weakness, but some of them did. And when they weakened on the folic acid, oftentimes, as I say, just on that one specific muscle that was recurrent, then I would take them off it. And I couldn't say that all these patients had a 5-MTHFR genetic variant or SNP, but some of them did, for sure. So with this new information guiding my investigations, I discontinued the folic acid in these patients who showed weakening on it and waited to see if they showed a need for some other type of folate support. So I waited a month or two till it could clear out the system. And some responded down the road to 5-MTHF form of folic acid, and others needed no folate supplementation even months later. So we just followed those patients, and we were able to get some of the patients off the folic acid. Now, I have had some patients on folic acid for a long time with no adverse effects, but some who had on for years would show some kind of an issue on some occasions. In addition, I've never seen a patient react to folic acid supplementation within 6 months of beginning to take it. What was described has only been observed in patients with long-term supplementation for years, not months. So I don't see this actually take place right away. Using muscle testing, we can learn a lot about patients, that if you see some study or you see some paper, you can identify if it really does apply to your specific patient that you have on the table at the moment. And with this continuing, then in my office, the most common supplement we recommended is 5-methyl tetrahydrofolate. Between me and my office partner, we estimate that about 30% of our patients are on a 5-MTHF supplement. We have what we might be characterized as a difficult patient practice, so one could surmise that in a more typical practice, it would be a lesser percentage. Even with 1 or 2 5-MTHF related SNPs, or methyl tetrahydrofolate related SNPs, some patients do well without supplementing 5-MTHF, though those are just a few by comparison to the many that do require supplementation, the many patients who do have the genetic variants who do require supplementation. What I have read suggests that about 35, maybe as high as 40%, or as low as 10%, depending on ethnicity, of the U.S. population has a 5-MTHFR SNP. That's 5-methylene tetrahydrofolate reductase, which is the enzyme that converts the precursor into 5-MTHF, the really most active form of folic acid. But as reported, there are a number of other methylation-related SNPs that must be considered that impact methylation process, including the MTR or MTRR SNPs, which are B12-related, and others which affect methylation. Methylation SNPs were discussed in the Immune 1 webinar this last fall. I recommend you review that. If you have any more question about it, we discussed a number of methylation-related SNPs. However, there is more to methylation discussion than mentioned in that webinar. In fact, there are whole courses available and dedicated to this subject. Many of you have taken those courses. I've taken a number of them myself. People who teach about methylation give warnings about when to start a methylation-related supplement. Quote, if you give it too soon, it can create problems, and so on and so forth. In my clinical experience, I have never had a problem giving 5-MTHF to any of my patients, and I've been using it since it was first introduced in 2002. I suspect that's because I follow the QA protocol, and the necessary protections to doing things in the wrong order are built into the QA protocol. It's 30-some plus years in the making, and those protections were built in based on muscle testing responses, but moreover, patient outcomes in the long run to see what to do first, next, and last. The only problem I have ever experienced when with 5-MTHF was when I consulted with a doctor regarding a genetic profile, and based on the profile alone, 5-MTHF supplementation was recommended. It seemed to be what the patient needed. The doctor treating the patient by phone recommended, because the patient was in another city for that doctor, recommended the 5-MTH supplement without any hands-on testing. The patient had an adverse reaction, likely because the QA protocol wasn't followed, and the 5-MTH was given not based on muscle testing and indicator testing outcomes, and probably in advance of corrections that should have been addressed prior to providing supplementation. If you do follow the QA protocol, what to do first, next, and last will guide you. You minimize these adverse reactions. And like I said, I've never seen one in a patient that I treated in my office when I gave 5-MTHF. Following the QA protocol and doing it in the order that was indicated. And there are a number of places in the QA protocol where 5-MTHF might be tested. And sometimes it's early on and sometimes it's later down in the protocol. But when we find it, we give it. We've never had trouble giving it following the QA protocol. I've witnessed many miracles with folic acid. The folic acid in the old days, supplementation with these folic acid products throughout my many years in practice, especially prior to 2002 when 5-MTHF first became available in the United States. I saw things before 2002, like relief of chronic pain, reversal of neurological problems, sometimes significant neurological problems, correction of immune system issues, resolution of difficult intestinal problems, and so on, using the folic acid that so many people are despising today, and yet it still worked for many, many years. And it still can work in some patients. But now that we have the 5-MTHF source, we test that and find it to be much more effective in most patients. I've also witnessed many miracles with the 5-MTHF supplementation, and you've heard me speak about many of these before, and maybe seen me do them in some of the seminars and webinars that we've taught. Like I've said many times, if I could have only one treatment tool in my practice, it would be injury recall technique. But similarly, if I could have only one supplement in my practice, it would be 5-MTHF. Whenever we consider using 5-MTHF, we must also consider methyl B12 and other methylation-related nutrients. So again, for more information on the various methylation-related genetic variants, the SNPs, please review the Immune System Part 1 webinar, Methylation and the Innate Immune System.